From Microbe TV, this is Infectious Disease Puscast episode 47, recorded on January 31st, 2024. Hello, everyone. I am Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. How are you today, Daniel?
I'm cold, Sara. There's been a bit of a cold snap here in New York, and I'm waiting for it to abate. And you are down somewhere a little bit warmer than?
Yeah, it's definitely not very cold out, relatively, I guess for me. So, but it's been not too bad.
Okay.
Yeah. Well, everyone, welcome. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, we will start with viral. Remember to listen to This Week in Virology, both the clinical update and the deep dive. And starting this section with the article, Evidence of Zika virus reinfection by genome diversity and antibody response analysis, Brazil, was recently published in Emerging Infectious Diseases. Looking at that important question, can you get Zika more than once? Here, the investigators were looking at Zika viral genomes in 135 persons. And while the genomic analysis is interesting, the very notable thing was that they detected reinfections, demonstrating that at least some people can get Zika more than once. Those people that got reinfected all generated high neutralizing antibodies, but then these folks contracted another Zika infection.
The next article is one I pulled from CID in support of breast or chest feeding by people with HIV in high income settings. As I suspect many of the podcast listeners probably know, the historical recommendations in the US and resource-rich settings was to actively discourage breastfeeding among women with HIV. But we have also updated you in a prior episode about how the newest DHHS perinatal guidelines in sometime early 2023 supported shared decision-making for infant feeding choices. So this is a really awesome viewpoint article presenting the reasons to fully embrace breast chest feeding as a viable and safe feeding option for HIV-exposed infants in high-income settings. They outline the benefits of breastfeeding for both baby and parent from a health standpoint, as well as cost and availability. There's also a description of the racial disparities related to breastfeeding initiation and some historical perspective, particularly among Black women in the U.S. The authors also provide some background into the timeline and sort of the path of data that we've had available, sharing the low rates of HIV transmission with current mother-to-child transmission efforts. So there have been transmissions of HIV in women on ART with undetectable HIV viral loads, a small number. So there are some unknown factors when it comes to applying U equals U to breastfeeding. But I really love this. Infant feeding, I would say, is a very deeply personal choice, and it's informed by a lot of different aspects of life. And of course, the goal of this by the authors was not to push away from or look down on formula or replacement feeding, but I think as many resources as we can to help readers get the information they need to have the best conversation with your patients is what we want. So I encourage people to check this out if they want a really nice, succinct summary of the literature that's out there.
Interesting. I've sort of caught it's an interesting terminology, right, Sara? The gender neutral chest feeding verbiage. So that may take a little while to catch on, but interesting that people are sensitive to that. The article Norovirus G2 wastewater monitoring for epidemiological surveillance was recently published in PLOS Water. Did you know there was a journal, PLOS Water?
Did not.
The background here is that with current approaches, we're great at looking back and saying there was an outbreak of norovirus, but not great at getting the information ahead of time, knowing to be on the outlook. the lookout. As the authors write, norovirus is strongly underreported due to individuals not seeking care or not being tested. I remember last time I had norovirus, I definitely was not seeking medical attention. I was basically seeking a toilet. As a result, norovirus surveillance using case reports and syndromic detection often lags rather than leads outbreaks. Here, the authors report that increased specificity and earlier detection of norovirus using wastewater compared to other data, and the ability to make this data available to healthcare, public health, and the public in a timely manner, suggesting that wastewater measurements of norovirus could enhance existing public health surveillance efforts of norovirus. And I sort of would like to see, this sort of, come out as like an alert, or again, as people check the weather on their phone, be nice to get an alert. Hey, norovirus activity is up in your area, and then maybe we can be a little bit more proactive instead of so reactive. All right. The article, Process Trial Effect of Duloxetine Premedication for Postherpetic Neuralgia Within 72 Hours of Herpes Zoster Reactivation, a Randomized Controlled Trial. So these are the results of a multi-center randomized open-label blinded endpoint trial that used a 1-to-1 duloxetine control ratio. So we got one, half the people getting duloxetine, half the people getting controls. Here they're looking at adults 50 years or older who presented with vesicles within 72 hours. The primary outcome was the incidence of postherpetic neuralgia at 12 weeks. So what happened to these folks with herpes zoster? A total of 375 were randomly assigned to the duloxetine group, 375 in control. No significant difference in the incidence of postherpetic neuralgia in the duloxetine group compared with the control group. The analysis produced similar results when they looked at so sort of, other factors, significant differences in the number of symptoms. So there maybe was a little bit less analgesic use, maybe some less opioid use, maybe some benefit to duloxetine impacting severity, but did not impact the primary outcome of postherpetic neuralgia. So I'm not sure I would report this as a negative study. You still may get postherpetic neuralgia, but duloxetine may have some role in actually decreasing the amount of analgesic, the amount of opioid use, and maybe the severity.
All right, I'll take us into our bacterial section. Be sure to listen to This Week in Microbiology. I pulled a paper from the Lancet that I'm sure many people saw was released. Efficacy and safety of an early oral switch in low-risk Staphylococcus aureus bloodstream infection, SABATO, an international open-label parallel group randomized controlled non-inferiority trial. So our podcast audience doesn't really need an introduction to our best friend, best nemesis, Staph aureus.
Best friends forever, BFF.
Yeah, BFF. BFF, best nemesis forever. So I think many people were anticipating this and had looked at the preprint. So the SABATO trial looks at early switch to oral therapy in patients that are low risk for or have low risk Staph aureus bacteremia. And we'll talk about what they mean by that. So we talked about sort of the setup, international open label randomized controlled non-inferiority trial. There were 31 tertiary care hospitals involved from Germany, France, the Netherlands, and Spain. Those with low risk Staph aureus bacteremia were assigned to oral antibiotics or continued IV therapy after 5 to 7 days of IV antibiotics. So the big question is, what is low risk? So their exclusion criteria for this were signs and symptoms of complicated infection. So deep-seated focus like endocarditis, pneumonia, infected implant, undrained abscess, impalement, osteomyelitis, septic shock within 4 days before assignment, prolonged bacteremia defined as 72 hours or more, and, quote, a body temp higher than 38 measured on both days before random assignment. So if they had persistent fevers. They were also excluded if they had non-removable foreign devices. So the catheter, if there was a catheter in place, that had to be removed within 4 days of the first blood culture. Severe comorbidity or other risks. For more detail on that, recent history of Staph aureus bacteremia within 3 months, IV injection drug use, immunosuppressed patients, prosthetic valves, or deep-seated vascular grafts, and then patients with ESRD, severe liver disease, prosthetic joint, and pacemakers were eligible if the infective focus was removed or if it was a skin soft tissue infection. And then again, these were all adult patients. So their composite primary endpoint was occurrence of any complication related to Staph aureus bacteremia bloodstream infection. So relapsing bacteremia, deep-seated infection, mortality attributable to infection within 90 days. And they assessed their intention to treat population and also looked at adverse effects. The trial was stopped and converted their interim analysis to a final analysis in 2018 due to low recruitment. So with the decrease in power, the non-inferiority margin of 5% was adjusted to 10% for the analysis. There were 5,063 patients with Staph aureus bacteremia that were screened. 213 were included in the intention to treat population. 108 were assigned to oral therapy and 105 to ongoing IV therapy. These were a majority male patients, 69%, and then the mean age was 64. And so for our outcomes, in the oral switch group, 14 or 13% of the participants met the primary endpoint versus 12% in the IV group. So it's a treatment difference of 0.7 percentage points, 95% confidence interval, -7.8 to 9.1, p-value of 0.013. The survival at 90 days was lower in the oral switch group numerically, but it was not statistically significant. So it was 83.86%. Sorry, I don't know what's going on with me. In the oral group, 89% in IV. And then for just a few other numbers, in the oral switch group, 34% of the 107 participants in the safety population had at least one serious adverse event, compared to 26% of the 103 patients in the IV group. So lower, but not significantly different. So the authors concluded, oral switch after 5 to 7 days was non-inferior to IV standard therapy. And those with low-risk disease, these patients completed 14 days of antibiotics. And I think probably the biggest question that people often have is what antibiotics did they actually use for the patients in the oral switch group? 58% were transitioned to cotrimoxazole, which is 160 milligrams of trimethoprim, 800 milligrams of sulfamethoxazole. 32% got clindamycin, 600 Q8 hours, and 9% received linezolid. So ultimately, this is a very small subset of patients with Staph aureus bacteremia, and I think the take-home of needing to search for possible complications remains, meaning these magical low-risk Staph aureus bacteremia patients that it seems like we often can't find, or it's a challenge to find. If you do happen to have one of these patients, then it probably is fine for them to switch to oral therapy. But I think people are also waiting on the SNAP trial as well.
Okay, the article, Guideline Concordant Antibiotic Therapy for the Hospital Treatment of Community-Acquired Pneumonia and 1-Year All-Cause and Cardiovascular Mortality in Older Adult Patients Surviving to Discharge, was published this month in Chest. What a mouthful. While several studies have shown that selection of empiric antibiotic treatment for community-acquired pneumonia that is concordant with clinical practice guidelines has been associated with improved short-term outcomes. Here, we're asking the question, what about longer-term outcomes? So they're going to look at 1,909 older, greater than 65 years of age, patients identified who survived hospitalization for community-acquired pneumonia at the Ottawa Hospital, Ontario, Canada, between 2004 2015. Here, they found that the selection of guideline concordant antibiotic therapy was associated with a trend toward lower all-cause mortality at 1 year, hazard ratio of 0.82. too. I want to sort of point that out. So when those folks are coming in and maybe you're doing ceftriaxone, azithromycin, guideline-based therapy, your 1-year all-cause mortality was 18% lower. Furthermore, the use of guideline concurrent antibiotic therapy was associated with a significant, almost 50% reduction in cardiovascular death risk 1 year following community-acquired pneumonia admission, and that was hazard ratio 0.53 with a p-value of 0.03. Okay. Now, I was a bit surprised by the results in the article. Outcomes of ceftriaxone compared with cefazolin or nafcillin, oxacillin for outpatient therapy for MSSA bloodstream infections. Results from a large United States claims database published in Open Forum Infectious Disease. What card-carrying infectious disease doc would use ceftriaxone in a situation like this? Well, here the investigators performed a retrospective cohort study using a large insurance claims database, queried from 2010 to 2018 for adults 18 to 64 with MSSA bloodstream infections. Patients discharged on cefazolin or oxacillin, nafcillin were compared with ceftriaxone with respect to 90-day hospital readmission with the same infection category and 90-day all-cause readmissions. Of 1,895 patients with MSSA bloodstream infection, 75.7% received cefazolin, oxacillin, or nafcillin, and about a quarter got ceftriaxone. Readmission due to the same infection category occurred in 19%, and all-cause readmission occurred in 28.3% within 90 days. Now, risk factors significantly associated with readmission with the same infection category were oldest sampled age, ICU stay during index admission, prosthetic joint infection, central line associated bloodstream infection, and endocarditis. Now, I was surprised to read that ceftriaxone was not associated with an increased risk of readmission with the same infection category or 90-day all-cause readmission when compared with oxacillin, nafcillin, cefazolin. I will add the caveat that patients with complicated bloodstream infections, such as endocarditis and epidural abscesses, were more likely to be prescribed cefazolin or oxacillin, nafcillin. So the groups were not really matched.
Yeah. Well, someone speaking of ceftriaxone, I'm curious what people think about this. This was from the Lancet Respiratory Medicine Journal. Ceftriaxone to prevent early ventilator-associated pneumonia in patients with acute brain injury, a multi-center, randomized, double-blind, placebo-controlled assessor mass superiority trial, aka the Profi-VAP study, which is excellent. As an acronym, it's descriptive and quick. So let's say 4 stars, not 5 totally, because it's, doesn't have something else clever in there. So this was conducted in 9 adult ICUs in 8 French university hospitals. They included adults on mechanical ventilation for at least 48 hours after an acute brain injury, head trauma, stroke, or subarachnoid hemorrhage. They received either ceftriaxone 2 grams or placebo once within the 12 hours following their tracheal intubation. They excluded patients such as those with a tumor, some sort of infectious disease process in the CNS, cardiac arrest, what was deemed high risk of death in the first 48 hours, if they were on ongoing antibiotics, if they've had a previous hospitalization in the last month, and if they had either nasal intubation or trach. The primary outcome was a proportion of patients developing early VAP from this window of the 2nd to the 7th day of being on mechanical ventilation. The analysis was reported in the modified intention to treat population. There were 171 patients who received ceftriaxone, 174 who received placebo. 319 patients were included in the final analysis. So that was 162 of the ceftriaxone group and 157 of the placebo. The incidence of early VAP was lower in the ceftriaxone group than the placebo group, 14% versus 32%, with a hazard ratio of 0.6. I think it is worth noting that the patients who had prophylaxis did have clinically significantly improved number of vent-free days, antibiotic-free days, ICU-free days, hospital-free days. So I think pretty important sort of patient metrics there. The difference in mortality was 15% versus 25% at day 28. That p-value there was 0.036. If you look at the secondary outcomes at day 60, so 2 months out, this leveled out a bit. So it was a mortality of 20% versus 30%. That p-value is 0.07. So the authors concluded that in patients with acute brain injury, a single ceftriaxone dose reduced the risk of early VAP, and they recommended incorporating a single early dose of ceftriaxone into VAP bundles. I didn't know much about this literature. There are 2 other trials called the Antarctic, and I don't know how to say this one, SUDDICU, which examined this similar theme of short course antibiotics for intubated patients. And seem to support this concept of prophylactic antibiotics in those intubated due to acute brain injury. But I realize as an ID consultant, we often aren't seeing these patients. So I don't have a great sense of how often this is actually being used.
Yeah, actually, I was on call this last weekend, and I spent a considerable amount of time in the neuro ICU. So,
yeah, I know we could call for so many other things. These are the patients we don't see. So interesting.
Yeah, no, I was sitting there for quite a bit of time. Some really, I think, fascinating, challenging cases. Will, but with the article "Azithromycin during routine well infant visits to prevent death" was recently published in New England Journal of Medicine. I have to admit, this was a topic that a friend of mine, Chuck Knersch, and I have been discussing, and there's a sort of history here. So prior investigators had shown that mass distribution of azithromycin to children 1 to 59 months of age reduced childhood all-cause mortality in sub-Saharan Africa, with the largest reduction seen among infants younger than 12 months of age. So seemed like a slam dunk. Let's just do a study and just look at those infants younger of 12 months. We'll see this great difference. So here the investigators, a little bit of humility, went ahead, conducted a randomized placebo-controlled trial of a single dose of azithromycin compared to placebo administered during infancy. So this is 5 to 12 weeks of age. And the primary endpoint was death before 6 months of age. Of the 32,877 infants enrolled from September 2019 through October 2022, a total of 16,416 infants were randomly assigned to placebo, 16,461 to placebo, 82 infants in the azithromycin group, 75 infants in the placebo group died before 6 months of age. So hazard ratio 1.09. The absolute difference in mortality was 0.04 percentage points. There was no evidence of an effect of azithromycin on mortality in any of the pre-specified subgroups, including subgroups defined according to age, sex, baseline weight. No evidence of a difference between the 2 trial groups and in the incidence of adverse events. So really sort of, I think, suggesting that there's something about giving it to this entire population of 1 to 59 months, somehow providing protection versus just targeting the first 12 months.
And I will wrap up our bacterial section with antimicrobial side effect that I did not know about. This actually was published online in the Pediatric ID journal in October, but I missed it. And I don't know if people know, I try to be pretty good about including things that are like recently published online, but I'm including this anyways because it's in the most recent issue. Ceftriaxone red wine urine syndrome in pediatric patients, a multicenter case series. The authors here describe 3 cases of immunocompromised children. The patients were from Guatemala, the UK, and Indonesia. All 3 patients developed benign red or purple urine with administration of ceftriaxone, which I have not encountered before. I learned that there have been case reports actually in older adults who had dark red urine with concurrent IV iron supplementation and ceftriaxone. But these cases were in absence of iron supplementation or other alternative explanations for the changes in the urine. In these cases, the patients had only received the iron-containing product of packed red blood cells. So they think the the thought is that this is related to the formation of complexes between cefiderocol and ferric ions. Although this is obviously just a few patients, I think an interesting benign phenomenon to see if you happen to find in patients that you're treating with cefiderocol. Does not seem to be harmful.
I like the pictures.
Sorry, I included pictures.
It would be quite frightening.
Yeah, it's pretty bad. So.
All right, not as frightening as the fungal section. Using insurance claims data to estimate blastomycosis incidence, Vermont, USA, 2011 through 2022 was published in EID. This seems to be getting a little bit of press. Epidemiology of blastomycosis in the United States is poorly understood. Geographic areas in the United States that have historically been considered endemic, based largely on sporadic case reports and a few documented outbreaks, include Midwestern, South Central, and Southeastern regions of the country, particularly adjacent to the Ohio and Mississippi rivers, Great Lakes, and St. Lawrence Seaway. In those areas, statewide annual incidence about 0.2 to 2 cases per 100,000. So I want you to think about that, right? So somewhere in the about 1 case per 100,000 persons. However, blastomycosis is not a nationally notifiable disease, and public health surveillance is limited to just 5 states: Arkansas, Louisiana, Michigan, Minnesota, and Wisconsin. In this study, based diagnosed cases identified in a review of claims data, they estimated the mean annual blastomycosis incidence was 1.8 patients per 100,000 persons during 2011 through 2020 in Vermont. So I'm trying to decide, I'm going to be doing my board research this coming fall. And are they going to update the question, or is it still going to be someone from the Ohio River Valley?
Yeah. I had another article in here that I normally don't get stuck on paywalls, but there was an article that came out on how to treat refractory aspergillosis. So if people have that article and want to email it to me, that would be awesome. But I have 2 other great fungal articles. This first one is from OFID, Challenges Facing Antimicrobial Stewardship Programs in the Endemic Region for Coccidioidomycosis. I'm definitely going to stumble my words. I'm going to say cocci. I appreciated learning from this paper, which discussed, issues related to diagnosis and management of cocci in an endemic region like Arizona and how that interacts with antimicrobial stewardship. And I know I had read about the proportion of CAP cases that are due to cocci in regions like the Southwest US. But I've never practiced there, so I don't really have a sense of how clinicians address this, or if they are adding something like empiric fluconazole to sort of a routine CAP case. And so I think I had assumed that the diagnosis and empiric treatment of this would be quite prevalent, but the paper shares how there is still a lack of awareness of and testing for cocci in Arizona and Southern California, with only somewhere between 2 to 13% or so getting tested for cocci, I'm going to, if they come in with CAP. And this is along with a lack of recognition for complications of or identifying disseminated infection with cocci. And so the authors did talk a bit about fluconazole use and how many of the available stewardship white papers or guidelines for sort of general, how should we deal with antifungal stewardship, don't really focus on cocci. They tend to focus on Candida and Aspergillus, so there's maybe a little bit less guidance there. So they did provide some recommendations for stewardship programs, which is outlined in their figure 1. So people can check it out, but they have a little prevention. It's a circle and it's split into 4. A prevention section, such as thinking about monitoring fluke usage related specifically to its prescribing for cocci prophylaxis, diagnostic stewardship and targeted education, management, of course, looking at how antifungals are actually used and looking at resistance surveillance, and then, of course, research and looking into future directions there. So that was really neat. And then this other fungal paper also was from OFID, Clinical Characteristics and Outcomes of Endemic Mycoses After Solid Organ Transplantation, a Comprehensive Review. This is a look at available data on 5 endemic mycoses and solid organ transplant recipients. So blasto, cocci, histo, paracoccidiomycosis, and talaromycosis. Not surprisingly, these fungal infections were associated often with disseminated disease and poor outcomes in these transplant patients. The authors point out how fever and cytopenias are common manifestations for these patients, and they sort of picked out some additional unique features, such as this association between HLH as a unique feature of histoplasmosis and how co-infection is commonly reported with Talaromyces. Oh, and I have our parasitic one.
Yes.
Wow, this is a very different episode. For parasites, please make sure to listen to This Week in Parasitism. I pulled another paper that it was mostly because the visual and the title really caught my eye from CMI. Tiny trematode bobbing its head. Daniel and I scroll through a lot of table of contents, so a catchy title really does grab your attention. But this picture was from a case of Fasciola hepatica. And the case actually started with epigastric pain and intermittent fever and vomiting in the setting of a positive echinococcus antibody. So the patient was treated with albendazole, and a year later, she presented with recurrent symptoms, and the ERCP revealed a live flatworm in the common bile duct. So I included the little picture there.
Very cute.
Right. What do you think of the picture, Daniel?
Very cute.
It's very cute. All right, and then I'll take us into our miscellaneous section. This article is from JPID's Infectious Diseases Evaluation of the Child with Suspected Hemophagocytic Lymphohistiocytosis, HLH. The authors from Cincinnati Children's here provide a model for evaluating patients with suspected HLH after opening actually with a pretty unique example scenario. It was a 6-year-old with 3 weeks of fever, splenomegaly, and a lab eval and bone marrow aspiration consistent with HLH. The patient was later found to have Leishmania mastigotes inside the macrophages. So very interesting. So they give a little background on HLH, how our current diagnostic paradigms can't really distinguish HLH from other hyperinflammatory states driven by infection or malignancy or as a result of rheumatologic conditions. For the ID evaluation, they give tips. We always love to have that thorough history to identify exposures, including travel or residence locations, even if it is remote, which was gathered later for their example case, or looking at their activities and so on. Their initial recommended workup are things that I think most of us would think about: blood cultures, EBV, adeno, HSV, and CMV testing, and then, of course, targeted testing based on the epi history. So Table 1 has this really nice list of pathogens and relevant exposures and what testing to send. And I also like Table 2, which looked at infectious mechanisms of immune dysregulation.
All right, and I will jump in with the article, Real-Life Assessment of BioFire Film Array Pneumonia Panel in Adults Hospitalized with Respiratory Illness, published in JID. In this study, BioFire detected significantly more pathogens, 350 bacteria, 16 atypicals, and 164 viruses than sputum culture, plus any standard of care testing. So 91% versus 60%. When compared with culture, the sensitivity of BioFire for individual bacteria was 46% to 100%, specificity 61 to 100, and negative predictive value 92 to 100. Cases were adjudicated as viral, bacterial. PCR detected bacteria in 55% of viral cases and 95% of bacterial. So the authors conclude multiplex PCR testing of sputa for bacteria is useful to rule out bacterial infection with added value to detect viruses and atypical bacteria. And I was just going to make a few comments. I am a huge fan of the respiratory pathogen panels for a number of reasons. One is it's so much nicer to actually have a diagnosis instead of like it's probably a virus. The other, maybe a call to action that, let's start using this information and not just treating everyone the same when we have this information. But there's also a patient safety issue, right? I mean, we're having issues where patients come in and they've got COVID and RSV RSV, they've got COVID and the flu. Maybe they've got human metapneumovirus or adenovirus or parainfluenza 3. That can also help us to put those patients in a place which does not put the rest of the folks in the hospital at risk.
I didn't read this one, but I need to. Yeah, I did not have access to the pneumonia BioFire lower respiratory tract one until a couple months ago, so I'm still getting used to using it. And I think this is my last one, but from the Lancet Infectious Diseases Gender and Geographical Representation at Infectious Diseases and Clinical Microbiology Conferences. This retrospective observational study of ECMID, so 2016 to 2023, and ID Week 2016 to 2021, found increasing representation by women, but overall underrepresentation, and they sort of go into the details. For ECMID, 47.6% of chairs and 43.6% of speaker positions were women. And this was, from a speaker position standpoint, increasing over recent years. Women were underrepresented in keynote lectures, but equally represented in the year in, XYZ session chairs, which is a very prominent session. At ID Week, 53% of moderators and 49% of speaker positions were women. The plenary and name lectures were gender balanced. And then they had a little bit of information on representation of low-income and middle-income countries among chairs and speakers at ECMID was about 10%. I thought I would just read this quote as a take-home from the article that, although reassuring at first sight, gender balance in the numbers of participants or combined chairs and speakers does not reflect true parity and prestige and representation. Assessing gender representation in speaker positions, particularly in prestigious sessions, could be an important future metric of success for comprehensive gender equity at conferences. So hopefully we'll continue to get more info on this.
Excellent. Well, I don't know if our listeners know, but I live in a very evidence-based household, and this is already impacting my behavior at home. The article Impacts of Lid Closure During Toilet Flushing and of Toilet Bowl Cleaning on Viral Contamination Services in the United States Restrooms was recently published in the American Journal of Infection Control and seems to have made a bit of a splash, including a discussion on TWIV. You like that? I worked on it for a while. Good. Just to focus on the highlights, I'm going to leave a link into the TWIV 1083 where they do a deep dive into this. Viral aerosols from toilet flushing pose a possible route of pathogen transmission. Now, toilet lid closure prior to flushing was believed to mitigate cross-contamination, but here the investigators show that toilet lid closure prior to flushing does not mitigate cross-contamination. It just flies out anyway. So, all right, you got to put the seat down for the ladies, but the top, you could just keep that up when you flush.
Well, that's a very unique end to this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
Yeah, and just not to be sexist, for anyone who wants to sit down, we should put the seat down. I like to sit down when I go at night. So anyway, you can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and keep sending those paper suggestions. Send them to puscast@microbe.tv. If you like what we do or you want us to just keep doing it, support the science shows at Microbe TV by going to microbe.tv/contribute or parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com.
And I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center at Parasites Without Borders, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.